We are basically talking about periprosthetic fracture, as a part of a THR, is a primary or revision THR. And this is a very common thing because periprosthetic fracture is probably the third most common reason for doing a revision hip replacement surgery. Now, the simplest classification and probably the most commonly used classification is a Vancouver classification by two guys called Duncan and Masri. So it is called Duncan's or Vancouver classification, and it's very simple. It's basically based on the location of a fracture. If a fracture is in a trochanteric area, it is type A. If the fracture is around the stem, it is type B. And if the fracture is below the stem, it is type C. And each of them are grouped into sub-fractures. Like type A trochanteric is divided at two types, AG, that is greater trochanter, and AL, that is lesser trochanter. Type B around the stem, again, is three types. If the stem is stable, the prosthesis is stable, is called B1, where the implant and bone junction is quite stable and the prosthesis has not become loose. If the prosthesis has become unstable because of either the fracture or prior to the fracture, it may have become little loose, then it is type B2. And if the bone is significantly lost, because this is a very common in a old THR where patient has undergone THR and the patient has got severe osteolysis around the prosthesis causing loss of bone, and the bone support is quite inadequate, and that is called type B3. So basically the B, which is around the stem, is segregated by the stability of the implant. Stable implant, unstable implant, and unstable implant with bad bone. And type C is below the tip of the implant, and usually this is a fracture like any other fracture. The only problem is the upper end of the fracture has got an implant, so we may not be able to put a standard nail or a standard plate. We may have to use some special type of implant to fix this fracture. Now this is a type A. You can see in a picture is a trochanteric fracture, and it could be greater trochanter or a lesser trochanter. Now let us dwell a little bit more on this type A fracture. Now, although the trochanteric fracture can happen because of fall, and you can see sometimes patient tripping while walking on a road, and they can get a avulsion of a trochanter, and that may be just a standard trochanteric injury. But many times there is a secondary osteolysis, and this osteolysis can usually cause weakening of a bone, and a very minor injury can cause a trochanter to just come off. So when a patient with so-called type A comes to you, it's very essential for the surgeon to ask the patient whether the patient has got any previous pain in the hip, whether the patient has got any previous injury, or whether the fracture, the THR is fresh one or an old one. Any type A fracture in a trochanteric area, which is happening when the THR is maybe 7, 8, 10-year old, you have to keep in your mind the possibility that there may be osteolysis, and that osteolysis may not be very visible unless you take a good quality X-ray, and that is the reason that this trochanter has fractured with a minimal injury. Because if there is an osteolysis and secondary, that is pathological fracture type A, then usually just fixing the trochanter will not work. The trochanter eventually will just come off, and then patient may end up requiring a second surgery where you may end up revising the whole stem. So you have to be very careful to label a fracture type A in these cases, because you have to identify that there is no osteolysis, because osteolysis in the trochanter may also mean osteolysis distally along the shaft, and that may mean that you are entering into type B, not in a type A, where it's actually a loosened implant, and fracture category may suddenly become B2 instead of A1. There are various ways to fix the fracture. Now there are wiring or tension band wiring, or there can be clips put on the trochanter. But as I mentioned before, if the surgeon doesn't recognize that there is osteolysis and just put the clip on the trochanter, this clip will break because there is no significant bone in the trochanter. In that situation, you may end up putting a second fixation. You may have to put a graft there, or you may have to put a long plate which anchor the trochanter down onto the shaft, using a long plate which is called a locking plate. And you can see that the two pictures below, the surgeon has gone back and redone the primary trochanteric fixation by using a long plate in a case of trochanteric fracture. So we have to be careful judging the type A injuries in a Vancouver classification. Now type B1 is actually a stable injury, where you can see that in a picture there is a cemented stem which has got a fracture going through the stem, but the proximal part of a stem has got a beautiful cement mantle. There is no radiolucency between the cement or a bone or an implant and a cement. And when that happens, actually, you may just have to fix the bone properly. Only thing is you have to be sure that this cement is not coming in a way. Now, when the bone is damaged because of osteolysis and the implant is loose, then this is called type B2 injury. And when the type B2 injury is there, there is a significant amount of osteolysis. And you can see that if you, in many of the cases, but sometimes you may not be able to visualize. So many times what we do is we take some kind of a long X-ray or some traction views, or even sometimes you can take a CT scan, but you need a Mars type of a CT scan where you can eliminate the metal artifact created by the implant. Otherwise, you can't see a good osteolytic area around it. So if you've got a Mars CT scan, it may be a good adjunct, additional test to identify whether it is a type B1 or B2. Because the treatment wise between B1 and B2, there is a huge difference. In B1, because we presume that implant is stable, we are just worried about fracture fixation, and a long plate sometime may be just enough. But in B2, the implant is loose and we are looking for revision. And there are a paper we have mentioned that almost about 30 to 40% of cases, when a surgeon has initially labeled the fracture as B1, may end up into B2 when they actually open the fracture and they actually try to treat it, and then they realize that the implant is not as stable as it looked on the pre-op X-ray. So you have to be very careful about B1 and B2 segregation. B3 is where there is a significant loss of bone, and you can see that in X-ray here, almost entire bone is lost in the proximal part of the femur. A bone osteolysis is seen, the implant and cement and bone junction is completely loose. You can see a large radiolucent line, and the lower end of the stem is actually has come out of the shaft. So this is type B3 with a significant loss of bone and loosening of the implant. And these cases require a much bigger operation, because you have to not only replace the joint, we also have to use a long stem, and you also have to use some kind of a bone reconstruction or augment in a proximal part to fill the biology of the structures around the implant. You cannot just replace it only with the implant unless you are using something like a tumor prosthesis. Now type C, as we mentioned, is below the tip, and this implant, where the implant is completely stable, it could be cemented, it could be non-cemented, but then type C has some two problems. Number one is if the implant is very close to the tip of the shaft, like in this particular patient, then you may have a cement mantle which has gone distally beyond the fracture line. And now you do not have much of an endosteal healing capacity. It is very essential for a surgeon to realize that when you talk about these type C implant or type C fractures, the bone has got internal cement and internal metal. So the endosteal part of the healing may not happen as we normally expect it to happen. So in that scenario, you have to be very, very gentle and careful about how you dissect the bone. We have to be very careful about preserving the soft tissues on the bone, because the periosteum, if you try to segregate and remove and try to get the raw bone and exposed bone, try to align it, even if you do it very well, anatomic and good, use a good implant to fix it, the biology of the fracture would have been damaged quite a lot. So you have to be very careful in this patient. It is not like a standard shaft femur fracture, because in this, the endosteal blood circulation is almost totally gone, especially if the implant cement mantle has gone distal to the fracture level. So you have to be very careful about dissection. You have to be anatomic in alignment. You cannot do a non-anatomic reduction here. So trochanteric type, as we mentioned, when there is a trochanteric injury, that is type A injury, if it is not displaced at all, it's just a crack, and you can see that it is not displaced, then we may treat closed without any surgery. We can just keep the patient in bed for rest and about 4 weeks or 6 weeks, and then mobilize them with the help of walker or a hip brace. But again, as I mentioned, conservative treatment in this situation doesn't usually work. If it is a displaced fracture, obviously we have to do operation. So this is just an example of type B1. And in type B1, because the cemented or uncemented implant is very good, we can see that you can reduce the implant, and after reduction you can either put a cerclage wires, which is the commonest thing which is normally used, so that the implant remains, and it has to be neutralized by a long plate. And ideally that long plate has to extend from the trochanteric tip right down up to the distal to the shaft of the implant. So you must have a plate which is long enough to have an anchorage into the trochanter. What you are seeing here is a plate which is going from trochanter, but although it would have been preferable to get that plate right up to the tip of the trochanter, and probably you could have taken the plate little bit longer and have given maybe 1 or 2 screw more, because there is a just 2 screws or 3 screws in a distal fragment. So we must neutralize this fracture when they put together by cerclage wire by using a long plate, so that the torsional forces are prevented. Sometime if you find that there is a significant amount of cement inside and the quality of bone is not very good, do not hesitate to put autograft taken from the iliac crest, and it has to be ideally an autograft which can help the healing of a bone. So that we are increasing the biological factors at the fracture and improve and create a situation for fracture healing. As I mentioned, articles have been published when we talk about B1 fractures. Is it really a B1 fracture? Now, as this Lindahl has mentioned in his article in 2006, many times it's difficult to assess the grade of periprosthetic fractures, and usually whatever you feel, the grade of a fracture can become one step beyond what you're seeing. So B1 can become B2 on table. So when you go for operation, you must make sure that you just don't go with with the preparation for fracture fixation only, but you must also keep full-fledged revision system ready, because on table you never know when you realize that this particular case will require a full-fledged revision and just a fixation may not be adequate. So this is one example of B2. We can see that there is a cemented implant, it's a cemented THR, and you can see that the fracture around the stem is there, and a proximal part there is a periprosthetic loosening. There is also cement bone junction radiolucent zones. So these are the cases where we know that this implant may not last very well, and you have to remove that implant and replace it with a longer implant. This patient had a significant amount of cement mantle distally, almost about 2 inches going beyond the tip of the primary implant. So this required removal by doing a osteotomy, and then use a long stem, and use a long stem cemented implant which was used. The patient was very elderly, and this has worked very well for the patient. Such fractures or patient, if they are a young patient, then maybe you can use a today long stem non-cemented implant, and we can see them later in a subsequent presentation. And these usually give a very good fixation, a biological fixation, and fixation along the entire shaft. Now type B3 is a complete loosening and a significant loss of implant, and a proximal bone will require now major reconstruction. You may need a bone grafting, or you may need a femur substituting implant, or you may need a large allograft and a prosthesis. Unfortunately, in Bombay, at least, we don't get a large allograft. So we end up using, if required, a femur substituting implants or a large prosthesis. So this is an X-ray, significant amount of loss of bone. You can see that the entire bone is shattered completely. with a huge amount of osteolysis around the shaft, and this was replaced by a long stem which was distally fixed. And this is not a case, this is case from a particular article by Gross and Kim, and they have mentioned about using a allograft, and they put the allograft, wire them together around the proximal part of implant, and then they help help them to heal. This is good option if you have an allograft ready and you can still reconstruct, but more often today we tend to use a large uh, tumor type implant which will replace the bone and get good distal fixation. So cortical only graft, again, revision surgery, biological bone plate sort of a thing can be used. And many articles have been published, but most of these articles are published below 2000, before 2000. So these are the articles from Burkhardt from 1987, article from Allen 1991, and they are mentioned about using this large cortical onlay graft from allograft. However, today we prefer a non-cemented large implant. So these are the cortical allograft. Again, the picture is from the book. I haven't done any of such cases myself because we don't get this graft, and they apparently help to reconstruct the bone, but we do not really know whether those grafts are actually completely incorporated. I can show you one of the case where I have revised a case where surgeon primarily has used these large cortical allograft and it has not healed, and eventually that failed and I had to do a re-revision. I'll show you one of that case subsequently in the next 1 hour. So these grafts are good provided you get them. Now, usually periprosthetic fracture when you treat, it has got a very high rate of complication. Dislocation rate is very high, refracture rate is very high, non-union of fracture can happen, and infection can happen. And some of the articles have mentioned 25% rate of complication or resurgeries because of any one of these three things. And we have to be very careful about doing this surgery because we need a lot of planning. And if you don't plan, you may end up having improper outcome and inadequate results. Many articles, this is from Danbury, Journal of JBJS America 2003, and they also mention that although there is a 90% survival at 5-year follow-up and 80% at 10-year follow-up, they have mentioned about a high rate of complication. The bone grafting, as they have mentioned, is a key for success, and a fully coated non-cemented stem are necessary. These cases should not be ideally done by cemented stem, because cemented stem, especially over a long length, if you cement the whole implant, will not last for a very long time.